although my presentation was informal and short.
Okay, the recording is on.
Thank you, Kaylee. This is a note for the recording and for the public that we have recessed IWG due to lack of a quorum. So what follows is our informal meeting where we will be discussing some parts of the agenda, but not all. The presentation by the Controller's Office related to the staffing and wages will be moved to the next meeting. And the group will continue talking as they have been. So do we want to start, Hillary, with kind of just a discussion with some of the things that you?
Hillary, you have slides. Would you like those to be shown or are you going off script?
No, I always try to stay on script.
Okay. So Kate, that's slide 9.
Dangerously. I'm just pulling up my top. Okay, so I'm presenting to an adjourned meeting. That's our recess meeting. Okay. Okay, so these are okay, I'm gonna focus. I'm sorry, I'm a little discombobulated. That's the controller's office.
Teams. I don't think Teams is on.
She may just be calling on Teams. That must be Valerie's team. So they're calling Valerie.
Yeah. Okay, I just quick Teams as far as I know.
Terrific. Okay. So I have some updates. And I'm not looking at my notes and I'm a little discombobulated. So I'm going to just talk from the slides and I hope I don't miss anything. So I wanted to just update the IW or the recessed group on, thank you, on CalAIM and our behavioral health services transition to EPIC, expansion of 5150 training and some progress we've made on implementing what we are calling culturally congruent care. Next slide. Yeah, that's great. Yeah. Okay.
This slide was not in the slide deck. You sent out.
That slide is
in, it came blank.
oh, that's interesting.
Came blank.
Yeah, we have
Yeah.
like a blank.
All right, we will get that to you then.
Okay.
Yeah. So I know we've mentioned CalAIM in this meeting, and I'm guessing some of you are more familiar than others. I am sharing this with you for both the buckets of work in CalAIM, where there is our opportunities for both opportunities and mandates for change, and some of the work that we are undertaking to comport with CalAIM. And to take advantage of some of the opportunities that it presents. So the major areas of activity in CalAIM include some payment reform, documentation reform, collaboration with managed care plans, something called enhanced care management and community supports, and very specifically contingency management. And so payment reform is really a major leg of CalAIM and is both an opportunity, but also represents really a sea change in the way behavioral health services in San Francisco will be billed and paid for. So it's a very, very big deal for us as a system. It's a big deal for both our colleagues in community-based organizations and for us as the county. So we are undertaking, thanks, Valerie. So we are undertaking really starting July 1st, new billing process using something called TPT codes. For those of you outside of the healthcare system, this is gobbledygook, I realize. But it is a really different way of doing business and looks more like the way the rest of healthcare does billing. So it's bringing behavioral health more in line with how the rest of healthcare in California and in many parts of the country do their billing and work. The other part of that billing and document work is that documentation is also changing, partly to follow the changes in billing and partly because of changes in the regulatory structure about how we deliver behavioral health services. So for example, we have a simplified documentation requirements. This looks closer to how clinicians, providers in primary care document care, and it's much less cumbersome. And our hope and dream is it will allow providers to become more nimble and not be as tied to, I think in our view, somewhat antiquated systems of approaching documentation of care. Additionally, within behavioral health, we are developing a new quality assurance unit, which will enable us to help providers, both our contracted providers and ourselves as a provider, to more effectively do documentation and billing. I know this, I can tell that for some of you, this is very dreary, but it is really important, and how we do business will look very different in the next couple of years. Additionally, we in the county, I think as all of you know, are the specialty behavioral health plan. We are the specialty mental health and substance use plan. But we also have in California the mainstream or physical health plan, San Francisco Health Plan, along with Anthem Blue Cross Blue Shield, now a little bit of Kaiser. And so we need to be working with those plans as we are together responsible for the majority of Medi-Cal enrollees in the city, the county. And this is sort of a way California organizes its managed care. It splits the benefit between the mainstream, this is sort of language from my last job, the physical health benefit, and people with mild and moderate behavioral health illness from the payment structure for people with severe behavioral health conditions. But the payer for their physical health stuff is another insurance company. And so that is, as you can imagine, from a healthcare financing point of view, really important that we coordinate amongst these different plans, and there are opportunities in CalAIM to do so. Lastly, the two bottom ones are sort of programmatic opportunities that we are aiming to take advantage of in CalAIM. And you've heard about these programs, so this is not breaking news, but this is the fact that they are embedded in a CalAIM benefit. First, enhanced care management is a program of enhancing payment for more intensive care management. We are working with the San Francisco Health Plan, who is essentially paying us for enhanced care management. Some of our best team members and some of citywide ICM are participating in this enhanced care management services. It's not changing the service, but it is changing some of the payment structures for the service. Another area that is new for CalAIM is payment for certain kinds of services called community supports. This is very carefully defined within CMS at the federal level and needs state approval. So what this means is services that have historically not been Medicaid or Medi-Cal reimbursable are under payment reform, under Medicaid reform. And we go through an application process to the state to get approved for that as Medicaid or Medi-Cal reimbursed service. So Soma Rise, in addition to our alcohol sobering, have been, alcohol sobering went live about a year ago. Soma Rise more recently as eligible for Medi-Cal reimbursement. That is good for us in San Francisco because it means we have an additional source of Medi-Cal revenue, which offsets general fund money with the idea that in tight budget years, it protects services from service cuts. In ample budget years, it allows for reinvestment of those general fund dollars. And then finally,
Does it include the managed alcohol program at the sobering or just the folks that come in?
I believe it's just sobering. But we'll find out. I'm pretty sure I'm correct, but yes. I don't think that managed alcohol would be approved. I just hypothesize. But I don't know. But I'm pretty, yeah. And then lastly is contingency management. So we have spoken with you all about contingency management. This is basically a substance use intervention where you reward participants for desirable behaviors, whether it is attending groups for substance use counseling, providing a negative urine toxicology if you are in treatment for substance use, attending an appointment. And so it's a studied intervention, particularly around stimulant use disorders, and it is the most effective intervention we have for stimulant use disorders. But it has been very thorny to implement for many different reasons, including the fact that we couldn't bill Medi-Cal for the service because it was considered a kickback to your patient for showing up. And so CMS had to weigh in that it was not considered a kickback. There was California legislation about a year and a half ago, so sponsored by Senator Weiner, that endorsed it locally in California as well. And so under CalAIM, we are able to pilot contingency management, and those pilots are beginning to be underway at the providers that you see here. That is HR 360, opioid treatment program at UCSF, and at the citywide at their STOP program. And I think close to launching, I think 2 of them have launched already. So we're very excited about that. And we intend to find ways to try to expand it further, whether it is in, I'm looking at Member Salinas, whether it is in some of our ICM programs, whether it is in our substance use programs, whether it is in our harm reduction programs, really thinking strategically about how we may try to expand on those services. Okay. I hope that wasn't too much. Next slide,
Can I ask a quick question?
Yeah. because we're
So
informally recessed.
I remember So I think what you're telling us is that you're getting new sources of funding. I mean, are these things that are currently ongoing based on county funding because there's no state funding for them?
If you go back up for a second, prior slide, whoever is controlling the slides.
Slide controller.
Haley, can you go back a slide?
So the bottom 2
Yeah.
are represent additional sources of Medi-Cal funding. That in the bottom one, contingency management, it's an entirely new service. So no offsets,
There's no offset.
right? In the second to last one, enhanced care management and community supports, there is the potential for some general fund offsets.
Okay, but at this point, you haven't actually penciled it out as to what that might be.
We have estimates and we are trying to budget conservatively so as to not spend the money before it's here and before we know exactly what we will be accruing. So it's a great experiment right now about what that's going to result. The top 3 do not hold the promise of more money, right? Except for the fact with our QA department, that will be setting up this coming year. We hope that will help us pull down more Medi-Cal dollars.
Okay.
And in fact, well, let me stop there.
We're a little concerned about our travel time reimbursement.
So there are challenges to some of the new payment structures that also cause us worries, including do you want to say a sentence or two more about that?
I mean, we have a lot of, we have clients all over the city and you have to, it takes significant amount of time to travel there, out to the Sunset, all the way out to the Admission. And with they will not be reimbursing for travel times. That's often
It's
travel time.
considered part of a bundled payment.
Travel time might be an
An
hour.
hour.
To go all the way out to, we have clients at the border of like with Daly City,
Sure.
getting there and back. So it'll be.
Be careful what you ask for.
Right. So this is exactly, and we all know this, you all know this, sort of a policy gets made and then best intentions and then gets rolled out and there are always bumps. And we are, committed to doing advocacy with the state, to working them through. We want to protect providers who are traveling to see clients. We think that's really obviously very important.
So also what ICM does, right? We're not very clinic based.
But this would affect other counties the same way,
Yes,
which probably have longer travel times.
that's a good point. Certainly rural counties will have longer travel times. Okay, next slide, Kaylee, thank you. The other very big thing that's going on, and you've heard me and us about this, is our transition to Epic, which is will be our new electronic health record or health system. At DPH, at the department as a whole, many of our coworkers are live on Epic and have been since 2019. And a few programmatic areas within BHS have actually converted or gone live on Epic. But we are planning a large transition of our own clinic as well as many of our CBO partners. We had a very big launch all week last week. We are intending for our full transition to be basically a year from now, in aiming for April 24. Right? Ooh.
Went down there. Yeah, I'm good. I just need to get.
So that will be a journey and we have really the whole of our IT department. We have a relatively new director of clinical informatics in behavioral health who's reporting up to Dr. Gonzalez in her role as co-chief medical officer, being supported by the department's informatics team. So this is a very also big transition and very important one. We expect, I'll just say a word because I know we talk a lot about data in this group, and we expect that transition to Epic will help us facilitate easier reporting and measurement in many of the areas that this group and others have raised.
I have a question, since we're on this, more informal. I asked Jennifer kind of before if this is great. Is there like a subject matter expert within the city that, I could volunteer to sit down with the group and just kind of take a look at Epic for like an hour or two to kind of report back? I don't think it's worth having somebody to get into the weeds of that, but I'd like to really understand how it works, how it's being rolled out, et cetera. Because I'm a big believer in what gets measured gets managed. And I really feel that the thing that's lacking in this group or mental health, San Francisco, all over the place, is the cohesiveness of, what's being measured and how it's managed. You may have somebody that's going to 5 different places because they're a vet, because they have this problem, they have this problem. How do we link all that and keep track of these people that are going to Selma rides or going to different places? And so I would like to volunteer myself to, if there's somebody that I could sit down with, that's like kind of the Epic guru or implementation person in the city, and just,
Let me-
program.
And are you familiar with
I
Epic?
have nothing, I have nothing. So that's what I'd like to see is like, I hate to put layers on it in qualifications and things, but I also, like how I envision this is that as you roll this out, and I don't know how it works, if it's a software thing. And, I think that every nonprofit or any group that's working with anything that has to do with mental health or homeless or anything, if they need to be using this and we need to measure and, I don't know how it infringes on patients' rights or data, et cetera. That's why I just want to have an idea. So that way, if I know how the cog works, et cetera, from the ground up, I might be able to better have recommendations and, bring it to the group. And, so that's why I just think this is a very important thing for me.
Yeah.
My biggest frustration in seeing this and all over the city is, the management is not well. And I think that maybe this is something that can measure and manage things a lot better. And so I'd like to know how it works and, because then I could speak to it better. Or so I'm volunteering myself. I don't think it's worth having somebody come in and wasting our time for an hour of a 3-hour meeting, getting into the weeds of this or how it works, but I don't know. So,
Yeah.
So on that,
Just pause for it. Steve, I want to make sure there's space for you in case, like, you're the virtual member, so I want to make sure that you have space if you have any questions that are coming up. Steve Fields? Or Steve?
Yes.
Yeah, you see, yeah. I wondered if there were any questions. We just wanted to make space for
No,
you.
I appreciate that. No. Everything's running fine. Thank you.
Okay.
so is Epic rolling out for your contracted providers?
Do you want to speak to that, Annie?
I can't speak a lot to it, but I know that some of them, and I don't think all of them are going to be on Epic, but there's going to be a way in which you can, if they're on a different system and it talks to each other, or they are able to take the information and upload it. I don't know that specific.
So at the moment, we are, as I understand, giving CBOs a menu of options. The goal is to have the data all in one place, I think to your point, and with several different mechanics of getting that done.
As long as you got interoperability.
So it may be, there are 3 different pathways. One, which is probably, from our point of view, the ideal pathway is that the organization starts using Epic. Epic is complex and is a very big lift for very small providers, just to be explicit. This is a
It's not user friendly.
It is a hard and complex, to Mike's question, thing to implement. So one pathway is everybody gets on, the organization gets on Epic. The next pathway is there's interoperability between 2 different electronic health systems that allow for importing and exporting and visibility of data, both directions. The third way, and probably least ideal, is that there's uploading of data into Epic. So Epic becomes sort of the central data repository, but that people in organizations where there isn't operability are able to view Epic. So to get the communication pathway, that's so important. I don't know the numbers of who's selecting which portion of those, and I think this is still getting worked through. The challenge is if you can't implement Epic, you're tiny. We don't want to lose some of those niche, community-based, very special providers to the fabric of our system because of inability
you want to make it a hurdle.
to implement right now. But things are not static either, and things will change over time.
So would a place like Soma Rise go on to Epic?
So, HR 360 is not in the room. I don't know.
I at least know they are partially on Epic.
They are
because
partially on
I
Epic.
don't know if they're fully on it, but they
Okay.
are using it. So
Okay, and then does Epic can you use Epic in the field? If you've got,
Yeah,
for example, crisis teams.
Yeah.
and the teams in the field
yes,
use Epic.
yes, on tablets.
Okay. That's good.
Good.
Yeah.
It's a good product.
Yeah.
They spent a lot of time thinking about it.
I just
That was on my big question mark today to follow up, you know.
Let me also just say though, if any of you have worked in an electronic record clinically, they're hard to do. Like it is, I mean, I have lived through as a primary care doctor in my primary care life, and then in my substance use treatment life, working in 2 different electronic health records, both of which I lived through transitions from one record to another. And it was vexing. I mean, just to be candid, it is not easy for providers. And I like to think of myself as reasonably electronically sophisticated, you know, reasonably digitally sophisticated and reasonably facile with screens and typing. And it was still hard. So I want to just extend a lot of grace to the many providers of many different levels, of many different organizations as they sort of come along with us. Like it really is important, I think, for the reasons you're mentioning about measurement and reporting and knowing what's going on, and bringing along multiple disciplines of multiple workforces and multiple organizations of different sizes and levels of sort of digital integration.
So given the complexity, I mean, it's gonna, when you open it up, it's gonna be complex.
Right.
Would you still be interested in?
I would, because I mean, I think that, you know, sometimes, you know, and for me, just to know, like, okay, is this used for billing purposes, Medicare, Medi-Cal, you know, to get money back or whatever, but I think just for, you know, we have, you know, we're in the technology hub of the world here in the Bay Area. And we always joke in the fire department, you know, for San Francisco, it's like yesterday's technology tomorrow, you know, and we're in San Francisco, you know, and it's like, you know, we have, you know, Salesforce and all these, you know, companies that, you know, want to help out, you know. Maybe we, you know, we get the biggest players involved in these things. Okay, well, we don't need, you know, Epic has the capability for all of these things, right? That you can have 260 fields. Well, why don't we narrow that down to the 16 necessary fields and, you know, dumb this down to make it a web-based, you know, operation where you don't have to load software, make it, you know, an hour an hour paperwork after somebody leaves that you can just, it's an intake for 5 minutes and it shares to a database that everybody is using. That's a web-based or something. I don't know. So that's why I'd like to figure out what it is, right? And then come with suggestions of, okay, can this be streamlined, be easier? To your point, right? So you have all these little niche things. You don't want to have a 5-person operation that's taking care of, you know, 20 people that are just doing great, that are, you know, deal with, you know, Spanish-speaking people that are over 50 or, you know, however it works, right? And then make that, well, you can't get money from us anymore because you're not using this thing. And they have no capability of ever implementing something like this. But to say like, hey, do you have a computer, right? The web, okay, go on this. It's multilingual. Fill out these 16 fields, hit submit, and then you log in, and then it's a database that everybody shares, right?
Well, I think
I don't know.
if I'm understanding Dr. Pence, it's like there are 3 options. So for the smaller, the most
Yeah.
CBOs, is that right? Like the ones that are like foreseeably they could do something like an Excel spreadsheet of the most important data and upload it.
Yeah.
Right.
Yes, I don't want to totally, I'm looking at Annie.
Like, well, technology becomes dangerous,
Yeah,
right? Like,
right.
I don't know the exact mechanism, but there is
Yeah.
some mechanism,
But
whether
it's some-
that's a
Yeah.
spreadsheet, a flat thing,
Yeah.
what is it
Flat
called?
file.
Flat.
Yeah.
The
Most
flat
systems
thing.
have, most systems have something.
Yeah.
Use.
Right.
It might,
Yeah.
Yeah.
They mean.
Right.
so it might be helpful to have like what I'm hearing is like, what you're looking for is integration, simplification, and streamlining.
Well, yeah, I mean, I just need to know, I can't even speak
Yeah.
to it because I don't know. So I'd like to sit down and at least have.
Doing a little bit. Yeah.
So we'll figure out something
Yeah.
either for the group or for you.
Yeah.
And I think just let me,
I don't want to waste the group's time on it because I think it's gonna be too, but I'd love to like kind of be the guinea pig to be like, hey, I don't know. So.
and I need to, I have 4 more minutes and then I'm going to leave, but then come back. So, yeah, let's leave it at that. Next slide. All right, we're going to do these last 3 slides. I know you guys are going to have more questions than I'll answer. So I wanted to make sure everyone was aware. I had mentioned this, I think, in our last meeting together. And I know the topic of 5150 hold has been of great interest to this group. So as I think everybody knows, a new California law was signed by updating the San Francisco Health Code to expand designation for who can initiate a 5150 hold to include members of the San Francisco Fire Department, specifically paramedics. So we are in the process as we speak of training, expanding our training to the department's community paramedics. The training has been happening, I believe, last week and this week. We are aiming to start July 1st. For paramedics who have successfully completed the training, they'll be able to themselves initiate a 5150 hold. Previously, in between when the law got signed last year and now, we had trained captains and acting captains. I know that there was sort of a robust conversation here that sometimes the captains are not on the rigs, and so there's a wait to get somebody to be able to write a hold, but now holds will be able to be written by community paramedics on the rigs. I think, as everyone knows, the last two bullets, a 5150 hold occurs when an adult who is experiencing a mental health crisis is involuntarily placed in a designated psychiatric facility for 72 hours. I just want to say, needless to say, this is really a last resort after de-escalation and attempts to engage the person and get them into a safer sort of place emotionally as well as physically. So we're excited about this. It's underway. We'll be working closely with the fire department, as we do with all of the designated providers, doing QA, reviewing cases, making sure we are all together in sort of who is eligible, making sure that folks get to care. And I think, as you've also heard, very importantly, through the OCC and our provider colleagues, making sure folks with 5150s receive appropriate follow-up and linkage to care, because ultimately that's what's going to change the course of their health and illness. Okay, last two slides, and then I'm going to race out, but we'll be back. Haley, can you, and next slide. I just wanted to update you on our work around our range of culturally congruent initiatives. You've heard about some of these in some of our, in my updates. We are really full throttle in a number of initiatives, and I want to make sure this group is aware of them. We are, right now, the Behavioral Health Services leadership is undertaking a 16-week equity executive fellowship, which started in May. We are working together to develop our understanding, analysis, and ultimately our practice of anti-racism in the department. You've heard on the next bullet about our Mental Health Services Act innovation intervention, that is to develop culturally congruent practices aimed at Black African-American clients at 4 of our own DPH civil service clinics. Sort of despite some slowness in hiring, we did recently hire for health workers and for behavioral health clinicians, and we'll be getting ready to implement those interventions, that service at 4 this month. We recently awarded an sort of in response to an RFP and in collaboration with our colleagues in maternal, child, adolescent health to fund 4 community-based organizations to support Black African-American pregnant, perinatal, or postpartum people through mental health screenings, linkages, and more. The funding was awarded to the 4 organizations you can see there: RAMS, Rafiki, Homeless Children's Network, and the UCSF, what's called Embrace program. This is really aiming to support people who are parenting or pregnant who are Black African-American. As you know, maternal mortality and infant mortality among Black African-Americans is the highest of any group, including in our city. And we are aiming to provide the important mental health, behavioral health linkages along with, of course, our colleagues doing perinatal care, physical health care. Another program to share with you is something called Universal Talk Therapy. We are partnering with the Human Rights Commission to offer a universal talk therapy program for Black African Americans via the UCSF Embrace program. And next slide. Again, I think as everyone is aware, overdose is continuing to be really tragic challenge for the country, but also the city of San Francisco. And Black African Americans are at highest risk. We are undertaking a number of initiatives to reach folks at risk in this community. One such effort is very focused overdose prevention training and education with organizations that serve or focus on Black African Americans. You can see the list there. We are looking to continue to partner with more organizations to push in more information about overdose prevention education that includes learning how to recognize, respond to overdose, carry, and administer naloxone, and know how to link people into ongoing care and treatment. We are also soon going to be issuing an RFP focused on overdose prevention for aiming for smaller community groups serving Black African Americans. And that RFP, I hope, will be out in the coming few weeks. More to come on overdose and wanted to leave you with that. I am going to run out and I apologize. I always talk longer than I intend, but we'll come back at 11.
Check and see if we're still here.
I will check. I'm only around the corner. So.
Yeah, we agreed to a time check now and then again at 10:30.
Okay, I will come back. And if you're not here, Valerie will let me know. Great to see everyone. Thank you for all your questions.
Thank you.
Thank you.
Valerie. So we did get word, we have 2 members who plan to attend, we're unable to attend because of family things that are happening in the family. So we are not going to hit quorum today. So would you have other things to continue on? The time check, would you like to continue? We have Soma Rise, we have some of the things to talk about with membership. And maybe we do a time check in a half hour again, or how are you feeling?
I defer to you guys who have to go places, yeah.
Because we're gonna just be discussing and then we can't really take actions.
Yeah.
If we're gonna just talk, then we're gonna have to talk again the next meeting, right?
Yes.
So I'm just thinking, should we just kind of adjourn? Because then I do have other work to do if I
Sure.
could catch up on my work.
Is there anything that we could talk about today that, to your point, which is a good point, that if we talked about it today, we would not then have to re-talk about it?
I can give my 2-3 minute spiel on Summer Rise since I'm not going to be here next month.
Okay.
But
Why don't we do that? And then let's talk about membership and kind of an update on that.
Yeah, that's fine.
Great, thank you.
So Katie, the Soma Rise slide is
There's nothing on
51. Oh, wait, no, sorry, it's before.
There's
that.
nothing on the Summer Rise slide.
Picture. 48.
yeah, so we went, geez, I can't remember now, was it early May, late April,
Yeah.
right?
Yeah. There were 3 of us.
Yeah, yeah, 3 of the members that were there. Here, so it was, impressive facility. I thought they doing a good job. My biggest kind of takeaways, and I hate to be negative, were just kind of, I was still confused after asking a lot of questions when I left as to what are the qualifiers to be able to be eligible to go into Soma Rise and be treated. So, and I still don't know. I don't know if you guys got that clear thing. I was a little disappointed in terms of seeing, where is the linkage, right? So it was kind of, I think it just felt like it was basically, a safe place for people to go and, lay down and come down from being on drugs and then are kind of like giving a pat on the back and are you okay now? And then they're out the door. So no linkage. And then also, and Epic integration was one of my big questions on that, and how are we measuring that? And that was kind of touched upon. And then, the nurses and care management profiles, where was the coordinated care and case management? So you have, some nurses there that, I was kind of talking to them like, okay, so, she's like, well, we don't really have anything and we're just here, but, I'll, maybe see somebody that I saw 2 weeks ago and say, hey, how's your ankle doing? Or how's that sore on your foot, et cetera. So it just seemed that it was underutilized for what it was being built up for. And maybe they're just getting it up and running. But for me, my biggest takeaways were, I still don't know who I could refer to go there, except if they're, high on drugs, that if they're only on alcohol, does not count. If they're not high at the time, that may not count. So it was still a little bit unclear to me. It seemed like it was like, oh, we'll take anybody. And oh no, well, we don't take these people, but yeah, we will. And so, and then just kind of, the linkage for them when they're ready to leave. I felt like there was no next steps. There was no, hey, let's get you over here, or, what do you need? And then just also the care for them. There's no profiles that these nurses that are working there all the time, like, that person's got, something wrong with them, physically or even just mentally, like, how are we addressing that? And it just seemed like there was none, or it was 100% reactive on the nurse's part and no proactive and no follow-up. And this, if this person's been here before. And so that was
Maybe I misunderstood what she said, but I thought the nurse said she's only there 1 or
Yeah.
2 days
Yeah.
a week.
2 days a week.
And it's not always the same nurse too. So if they're on vacation or something, yeah.
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 So, and I guess, and then they have backup.
Yeah.
But only would have backup if there was a need for backup,
Right.
as opposed to a nurse being there
Mhm.
who could be more proactive.
Yeah.
I'm similar to what James just said. My concern is that this is another program, another entry program where there seems to be an entry, but there is no exit into
Something.
Yeah.
something.
Yeah.
Yep.
And that it's, I mean, literally someone could come for up to 24 hours, walk out the door and come back 2 hours later
Yep.
and get another 24 hours.
Exactly.
Right.
Yes, that's right.
And I think there were some data issues
Huh?
about calculating just how much you've got in terms of repeat business.
Mhm. I didn't
Uh,
know.
But also, I think the numbers we saw a couple of months ago indicated that very few of those who come in the door enter into a larger, into the larger system.
And I think that that's where it just caught me surprised where, they said there are a lot of repeaters. And then how they come back is that they leave for a couple hours
Mhm.
and then the clock starts again.
Yeah.
Well, if they frequent, return people, then maybe that's an opportunity to get them into something. I was more into focus on, okay, this is wonderful.
Yeah.
It's a stop place, but let's get them somewhere so that they don't have to keep coming back, because then this might be an opportunity for people to come through to get into something more of a long term to get into
Yeah.
treatment. So that's where I was kind of stuck to.
Yeah. I mean, it's similar in the sense that it's one more outreach program in which there's an outreach, but there's no what to say?
Same.
Reach. I mean, where there's no connection into the care system.
Lots of linkages to nothing.
Yes.
Yeah.
Yep.
I mean, it's a nice place, nice setup,
Yeah.
nice everything, but again, it's that there are other similar systems out there, but then yet again, we're trying to see whether or not we can get something for these people so they don't have to keep revolving the same.
Mhm.
But you're right. It's a very nice program.
Yeah.
Yeah.
Maybe with the new contingency management programs that are rolling out with CalAIM, it's an opportunity to get, but they have to get linked to a service provider. Yeah, and because you have to be, if you're in contingency management, there is a lot of continuous engagement with a provider that's going to
Yeah.
track the things that you're accomplishing, whatever is going to set goals with you, right? And measurements, and then, be able to do the disbursements, and it's pretty involved, so.
Maybe it's a slimmed down version of Epic that everybody uses.
Steve Fields?
Yeah.
Want to make sure that, do you have any questions or thoughts about Summarize?
Yeah, I'd like to, I do have a question that's just technical, which is how I might raise my hand. I don't see any option for me on that. I think they assume I'm there in person or something, but I don't see the icon for me doing that. But yeah, we have a regular discussion that at some point I think is going to have to get engaged, which is how do you keep doing outreach and not be expanding the treatment options for people? And I think that's going to be an important part for MHSF. I don't know how many people know, but in the 24-hour treatment system for clients of the system of care, there are currently 3 programs that are not accepting referrals because they can't recruit staff. And I'm kind of disappointed that we weren't able to engage today in the wage and discussion around workers from the controller's office. We have lost beds to the system. They're not gone, but they're not, we can't recruit and hire. Health Right 360 may have some of the same pressures. Certainly Baker Place's PRC experienced that, and we're still not out of that crisis. And Progress Foundation has one acute diversion program that's still not open to referrals because we can't staff it. So while we're talking about expanding the system of care in a way in which the people who need it that we keep finding on the street or finding in strong programs like Summarize, there's no place to go. And we can't keep explaining it in the context of people refusing treatment. Which is another subset of an interesting discussion for all of us. I've worked in the people refusing treatment world for 40 years, and it's never been discussed in a complicated way. There's all sorts of dynamics that go into people who presume to be refusing treatment, and we have not engaged on how people who have managed to get people in programs, stay there, and complete programs were often the very same people who were saying, I don't want anything. We've got to stop having these simple explanations for why things aren't working and start digging a little deeper into what our system of care needs to be able to respond effectively to the people we all know are out there that we keep finding who aren't linking to services. And that's going to be the challenge of MHSF going forward is what do we offer in the way of treatment, support, and other things that will get people engaged? And it's way too simple for us to say people are asked if they want treatment and they say no. We just check the box. It's a much more complicated obligation we have to our clients not to just accept that answer, but to explain what kind of treatment might be available and that it helps a whole lot to have that treatment actually exist. Thanks.
Which I think to the point of what Andrea was talking about, hopefully the contingent management piece can actually play a better role in really connecting and linking folks to longer term of, stability, and wellness.
I'm not sure I should raise this, but I'm going to. I was at a town hall about 2 weeks ago, which included the chief of police, the DA, and David Chu, city attorney. And this question came up as to, for those who are sort of going through the criminal justice system, who have substance abuse issues, that there is just a complete refusal of anybody to accept mental health care. And the DA's view, and I think I'm accurately quoting her, is that folks aren't wired to accept care. I'm just curious whether that's something that those of you who are more knowledgeable about the mental health system and the entry to the mental health system, whether you've got a group of folks who just don't want care because they're, quote, not wired to get health care. I'm not sure. I'm not saying I agreed with that. It just struck me.
It's interesting language. I
She used the word wired. I know she.
Yeah, like it's something in your brain circuitry that
Yeah.
prevents you, and on some level, yes, but I think it's more about like what stage are you in the, kind of recognizing that you have a problem and, deciding that you need, contemplation, do you want to accept care, then like action, like, I think it's more that than, yes, on a really basic level, yes, but,
I think that it's also, people, it's in a context that started, 30, 40, 50 years ago. I mean, things happened before and you don't know how many times this person has looked for help in the past and they've given up hope, right? I mean, that's not like wiring. That's like, how hopeless are you, right? And also, have we created the conditions for, I mean, like, again, I said that thing about contingency management, but at the same time, I was thinking about all these folks are homeless. Like the folks that are going to summarize are homeless, right? And so we're started doing contingency management at Citywide, but the folks that we're doing that with are clients that are housed, So it's very hard, none of the conditions are there to set you up to succeed.
Yeah.
Right. You can go to Health Right 360 and do 90 days and maybe there'll be a transitional bed.
Yeah.
Maybe there's not. So then you just back out on the street. Right. So I think also if you're presenting something with a clear pathway out, but folks are getting presented something that's completely opaque, vague, what's going to happen is from there is completely uncertain. You're giving them a package of uncertainty with you're trying to give them, I don't know, some Cheetos and maybe on the other side, you'll get a full dinner, maybe not. And so that's also the thing. Like if we can present clear pathways out, where you can make seamless transitions. Like I think, where you can make, or fairly seem, not that there's not going to be bumps. So like people aren't expecting not to have bumps, but fairly seamless transition from one level to the next, but we don't have that.
I mean, this could be a topic for a future meeting to talk about barriers to entry that are unrelated. They're basically on the user side as opposed to the provider side. We know we have barriers on the provider side in terms of the lack of housing and issues in terms of staffing and so forth. But there clearly seems to be barriers on the user side, on the consumer side.
And could I add to that discussion? Because there's a lot of discussion around care court and various forms of compulsory treatment, which is what the system always jumps to very quickly before it looks at itself. But one of the things that doesn't get often, and that's where this hardwired thing really drives me crazy. I don't have a whole lot of patience for the criminal justice system describing the clinical process in an inadequately developed system. But one of the key parts of contingency management for persons with severe mental illness and substance use is the choice is better than the other choice they're looking at. And there's a lot more actual thinking that goes into what we see as resistance to certain kinds of treatment. When Progress Foundation opened the first acute diversion program really in the country in 1978 at La Posada, everybody told me, all the experts at the hospital, these clients don't want treatment, so they're not going to go there. So if you try to divert them from the emergency room, they're not going to want it. And we found the exact opposite to be true. When the hospital was full, then the hospital cooperated with us around diversion. And when you told individuals what was available to them right then, not a week from now, not 2 months from now, but a bed and a house in the community where there was 24-hour-a-day Spanish-speaking staff, where they could wear their own clothing, or they would be part of a treatment system that was voluntary, not involuntary, and you'd have a bed and a place to sleep and food, they picked the program over the hospital because they didn't want to go to the hospital. They'd been there many times. If we offer choices that are attractive, that's a form of contingency management in the treatment system. But if we're not offering that choice, then we pathologize the resistance to treatment. We're missing the point. And so, the most simple form of that is if somebody is seen on the street and we talk to them and say, would you like to go into treatment? And they kind of say, yeah, I'm finally burned out on this. And Vitka would know this process. Maybe 3 times it takes someone to try treatment before they're committed. And they say, yeah, I'm ready to go. And they'd say, okay, there's only one problem. We don't have an available bed for another 10 days or 3 weeks or a month. So can you hold on to that commitment to treatment for another month, and then we'll get you into a program. We can't avoid responsibility for that part of the decision-making process that the individuals who are looking for help have to make. And we're too quick to try and attribute it to their illness or their addiction, but we aren't offering enough choices in a timely way for people. And that's another form of contingency management. And we're too slow on developing that. I've yet to see a report on developing the community treatment system, particularly in the 24-hour care. They added the programs out at Treasure Island, which is a great move. But they still have a lot of work to do in the community on this. And I think we'll be surprised by the people who choose a place that's safe and then get implicated in the value of treatment if we just have it available at the moment that they're in crisis. Thank you.
It comes back to the topic of system. I mean, we've talked about system flow and wanting to see what an ideal, some sort of mapping, because that's something we have to then we have to take the steps to get there, right? Like, I think that's supposed to be the point of mental health SF is improving system flow, but we don't have any sort of vision of what that would be, and then therefore what we're working towards. I mean, so it's all still comes back to there's no system flow here.
Yeah. Well, and I think just the next meeting we are scheduled to talk about system flow with the mapping. Was that July or August? Okay, it's coming because they're working on the flows and they're working on a community engagement process, both with providers and consumers, to take a look at that flow, the ideal flow, and then talk about where the flow is not happening.
Yeah, very nice.
Yeah.
Well, we're on it since we're recessed and can talk about things. We wanted to talk about this today, but so we have engaged Interethnica for community engagement around mapping. And they had some feedback about sort of the proposed flows that come up from this group and how those might work in a discussion group or in a focus group with providers and consumers. I think they have some reasonable concerns that if we present very narrow flows, it will be difficult to have much of a conversation about those, and not necessarily everyone in the room will have enough sort of specific knowledge to like a specific population or something to be able to respond to it. So we wanted to talk about using that community engagement as an opportunity to get sort of broader feedback on the system from them, and then using that to feedback into the flows and the maps that we're developing. But we wanted to see if we could do a brief discussion group with some members of the IWG in the interim with Interethnica to get your feedback on how we would present that. So you'll see a request for that go out. And that's just really what the intention is to use, make it good research if we're going to actually gather people and make them answer questions, and then make sure that those are like feeding back into the flows. And then I want to remind everybody, Supervisor Roden has called a hearing on our system of care. The description looks very much like mapping. That is how we are approaching it, is basically mapping the entire system of care and presenting it in a hearing which we think will be in like September or October. So we will be doing that very robustly in a public forum. So So stay tuned on that. So that's gonna be a big one. Anyway,
Yeah.
go back over.
You don't have to go to the wall.
Yeah. The wall.
I mean, so just, there will be a post communication out to everyone here for discussion group 4 to talk a little bit about what those flows are with Interethnica to put into place a good community engagement process.
So I know you want to try to get out of here, but can we talk about,
Yes.
about where we're going? Because we already know we have one member who will be here next time.
One member what?
We have one member who we know will be out of the country.
Yeah.
Time of our next.
Moving along.
So let's
all
talk-
of us.
Yeah, let's. talk about-
All right, well, you gotta babysit my kids then.
I
One
don't,
night.
well, I got enough children.
Why can't you zoom in?
But they wouldn't let Sarah
See,
today.
What, let's see, you guys start at
No,
9
no,
a.m.?
no.
Yeah, let's talk a little bit about membership
Yeah.
Haley, this is slide 59.
and just, can I see, are there any members from the public? I see. Just a reminder, members of the public, we do not have forum to meet. We're not taking actions. We're just reviewing a little bit of information before we close the recessed meeting.
Reach out for somebody to C3. Get somebody into C3.
So in terms of membership and government, we have a corrected table. My apologies again, Member Wong and Member Schroeder for the error that we had previously. We are waiting for the Rules Committee, the Board of Supervisors, for the timeline on processing the applications that we do have. I don't know yet when those will be calendared. We have asked to try to get them in July. There's a couple of time options in July. I know that there is a large queue of a number of other committees hoping for the same thing. So we are hopeful that we can get those applications through the Rules Committee and processed in July. But if it's the end of July, that may also affect the July meeting and being able to meet quorum for the July meeting. So I think meeting quorum for July meeting with vacations and the timeline for processing the applications feels not sure to me yet. And then the other concern is that I think we simply don't have enough like recent applications to get us to full membership anytime soon. So we need help from all of you and from within our own system to nominate people to like give us names to.
I'm working on somebody for C3.
Wonderful. I'm good.
Three's been vacant for how long? More than 14 months.
Yeah, a very long time.
The person
That was-
only
that was vacant when
attended
you and
the
I
first
joined.
6
Yeah.
months.
Yeah.
That person only attended the first 6 months.
And I want to acknowledge, you know,
That's fine.
this is not it's not paid, it's a lot to do for a volunteer thing. So I have drafted a little cheat sheet, as I think was requested at the last meeting, for like how to apply. I can send that out after this meeting. I can send guidance for you, Member Wrong, on how to like continue your seat. It goes through the same process as a new seat. There's no issue with you continuing in the interim. And same for you for filling in. There's no like prohibition on you continuing to hold this until it's filled, but we want to give you the chance to.
Is it,
Can Vitka come? I mean, so Vitka, I mean, she's just done, I mean, because Vitka Glenn could also.
She could also, I think it's balancing like
Like,
your capacity, like other things that are happening for people.
Yeah.
You know, it's.
Yeah.
would it be better to ask the board to reduce the size of the IWG from maybe 11 members?
It's not something that could be acted on quickly, I think, and would likely open up, I think, a broader.
Has it been communicated to the Ronan, Mandelman, whatever subcommittee that this body does not have
It has, and
ensure a quorum?
it has, and we, once the budget conversation winds down, we're gonna lean in on it more as well, so. So we're trying to go through our our own working relationship with our city partners to push applications through. But it's not just moving the applications. We need more names. We need folks to apply, basically. So, and I think it is easier when we're taking recommendations from our like known community. Yeah. So.
I mean, it's easy for me because I'm not, you know,
Is the volume good for you? Are you able to hear all of this? Steve Fields, are you able to hear, is the volume okay for you to hear?
Sorry, I'm on mute. Yes, it's just fine. I can hear well. Thank you.
Sorry,
Your voice was dropping.
I was a mumbler.
yeah, I just think it's not fair that you get, I mean, everybody, I'm the only one probably in the room who's not working full-time. But for everybody who's working full-time, it's a lot to ask you to come to a meeting and then not have a meeting. And it's, you know, it's, I mean, I don't know how we communicate that something's wrong here.
We sent another nudge yesterday. I think at this point, we're in the queue. We have conveyed the urgency of, you know, of our position and we'll have to continue to that. I don't know about July. I think they've heard us that it is urgent to process our applications that can move forward in July, but I was looking through the applications we have and most of them are quite old. There's only one that's new. So
There are three at the board. I understand that the board process is more torture, but the mayor's got 2 slots also. And is that just not moving? Is that also immovable?
I think that is something where if you would, it would be helpful to have your guys' participation in elevating that concern. We phrase that concern, I think.
We can't vote to do that.
Can't vote to do it, but you can do it personally. So
What's a good channel for that?
anyone you know at the mayor's office is a
Okay. Sure.
Yeah.
Yeah.
So,
That was
you know, these things, squeaky wheels matter.
Yeah.
Yeah. So,
understood.
Yeah.
Message received.
So there's no applications for Vicka's. So she was seat 5? She's seat 5?
yes.
Because seat 9 was Dr. Rye from Baker, and that's never
Is that the other seat that's been vacant?
for a year. He's up to a year ago.
Seat 8? That's a behavioral license.
I mean, Valerie, is it possible, I mean, you contract with most of these types of programs, don't you?
Mhm.
Is it possible to do some outreach to see if one of these programs has somebody who'd be willing to?
So we've done that a number of times in the past without a much of a response.
We offered donuts.
Yeah, I was gonna say, so
Okay.
I think that there's some considerations as we always continue to look at like governance and how we run these meetings and the demands and expectations on all of you too, that may contribute to why we've not had a strong response. It's a heavy lift and I acknowledge that. So, but we haven't pushed those same channels in a while. We can do it again. It has actually over the like 14 months that seat's been open, we have.
I mean, I could think of some providers, I don't, not personally, but I mean, there must be some providers who might want to seat at the table.
Yeah.
They might be willing to commit somebody who
Yeah.
could be a seat at the table for that purpose.
But I would encourage you too, that sometimes it's, you know, like your voice is heard differently than ours. And so
Yeah.
it can be helpful to have outreach from
Okay.
members as well. So.
I apologize. I thought we were going to get 10:30, so I have a ride.
No, that's fine.
All right.
Thank you. I will be in communication about the July meeting as we come close. Thank you, members of the public, for
See you all in August in person.
Have fun.
Have a safe trip.
Yeah, have a good trip. Thank you.
Thank you.
Okay,
Thank
you
you.
could stop the recording.
Okay.
And if
Thank you.